Hello, and welcome to our special live event on Living with NBIA during the COVID-19 pandemic, presented by the NBIA Disorders Association. We are so pleased you could join us and appreciate those of you who submitted questions in advance. I'm Patricia Wood, president of the organization and today's moderator. At the NBIA Disorders Association, we know that easily accessible resources and accurate, reliable information are critical for you and your loved ones. We also know that during this unprecedented time, many NBIA individuals and their caregivers are feeling more anxious than usual. We believe this webinar will provide useful information and some comfort during this difficult time. The NBIA Disorders Association was founded to help NBI families, and that's why we are here today. Remember, you are not alone. We are all in this together. With just 2 days' notice of this event, we have families registered from 17 countries and from coast to coast in the US. And that doesn't include those watching live on our Facebook page right now. If you can't stay for the entire event, we will have a recording available for later viewing, and we'll share highlights of the webinar online. I'd like to thank our expert panel who volunteered their time to discuss your concerns about COVID-19. They are Dr. Susan Hayflick, Dr. Penelope Hogarth, and Allison Gregory, all from Oregon Health and Science University. They are joined by Katie Flores, a speech-language pathologist at Open Door Pediatric Therapy in Houston, Texas. She will address coping with the absence of regular therapy sessions and finding other options. Our panel has questions that were submitted in advance, and we will address new questions submitted during the webinar, time permitting. And now I would like to turn the program over to our first speaker, and that is Allison Gregory, who will share with us on how to keep your loved ones safe.
Okay, I just unmuted myself. Hopefully everybody can hear me now. I'm getting a thumbs up from Susan. I haven't laid eyes on Susan and Penny for a month, so this is kind of fun for me too. So how to keep your loved ones safe. What I want to do is take about 5 to 10 minutes to talk about that. Susan and Penny and the rest of us are also going to speak later specifically about what to do if your child needs to be hospitalized, and also which individuals or children might be more fragile or have greater risks for certain things. So I'm not going to go into those details. I'm really going to stick to the basics of what I hope might be some extra tips for keeping loved ones safe. And this is a really hard question. So we posted something on our website and on our Facebook last week because we've been getting questions about this from you all, and we've been discussing it as well. And I think one thing is to understand that we can't make a specific recommendation for BPAN or for PLAN or PCAN or MPAN. We at OHSU, our thinking is you need to look at your loved one as an individual and really assess based on their history and their current health status, what is their current risk? What is their current health status? And that's going to be a very broad spectrum within NBIA. Some people are very fragile. I think you know who you are. Others are incredibly robust and healthy and are probably doing better than most of us during all this. So, think about their secondary issues, their ongoing chronic issues, and make your own assessment with your local team about how concerned or maybe how cautious you need to be during this time, and that'll really help you weigh some of the risks and benefits when I talk about keeping people safe. So I'm not going to go into the core principles because I think we could all recite them in our sleep by now about hand washing, physical distancing, and sanitizing high-touch surfaces. What I've tried to do with Patty's help is identify some issues maybe that are more on your minds and that could be addressed a little bit differently. So one thing is, we've all been told to varying degrees in our different states to stay home as much as possible, to really only go out if you need to get food, to go to a necessary medical appointment, to pick up a prescription. So it is reasonable in these instances, based on your assessment of your loved one with NBIA, to be thinking, do I need to go to the store and be wandering in there for an hour exposing myself to things, or could I use their pickup service? Or am I lucky enough that there's a delivery service? Could a friend go for me? These are the types of things that we're all thinking about. And I think, you know, whether you're in an urban, suburban, rural area, you're going to have different resources available to you. So I realize it's easy for me to say, it's probably just not possible for some of you. I've been super lucky. I've been picking things up once a week where somebody loads it all in the back of my car and I say, thank you, you know, in the rearview mirror. And I don't have a fragile child at home. I have two pretty robust teenagers at home who are making me crazy. So part of this is your own individual tolerance to risk and what you're willing to do. We did have some specific questions about blended families and kids in situations where normally they would be going back and forth, you know, in a joint custody situation, maybe between two homes. We don't have specific recommendations about that. I think it's more your own assessment of how fragile or how robust is your person with NBIA. And I think you also need to factor in, if they are shuttling between two homes, how many other people are coming in and out of those homes? It may be that they're really locked down and that it's, you know, a two-person home and nobody's really coming and going that much. But I have seen, you know, in my neighborhood and other places, other homes where I see girlfriends and, you know, friends coming and going. And so you just need to assess, you know, how much, how small is your circle or how big is your circle in a situation like that. There are situations where we probably all need to go out, and that includes individuals with NBIA. I know, you know, we're going to talk later about the co-AZ trial. We're still sending people out for necessary safety blood draws in that trial. I'm sure some of you on deferaprone have blood draws you're supposed to be doing. There are other situations, seizure meds, where you might still need to go out. And what we've been recommending in those situations is just taking steps to reduce exposure as much as you can, meaning call ahead. And I've been learning to always call and figure out the lay of the land. Some people only have a certain number of people allowed in their waiting rooms anymore. So when I go for my allergy shot, I call from the car, can I come in? Is there enough room for me now? And we figure that out. Call ahead, figure out, are there slow times? If you show up, you know, 10 minutes before they open, is that better? Can you try to slide in at the end of the day? There are different strategies for this. You can also have your loved one wait in the car. You know, if you're the one willing to go in, check them in, figure out what's going on in the waiting room, leave them in the car with somebody else and just whisk them in right away when they're ready. And then sanitize everybody's hands on your way back out. You know, just everything that we can do to control a situation that's really out of our control for the most part. The other thing I wanted to talk about is, you know, when we can't stay home, when we're going out and about, there's a few things to consider. One is, and I talked to Susan about this a little bit, the original recommendation, or the recommendation that still stands, is that we're all supposed to be physically distancing at 6 feet apart. And we've seen the tape on the ground, and we're all thinking about, you know, in Canada, it's a hockey stick, right? We're all staying 6 feet apart. And this is still the current recommendation. And that's based on this idea that when you sneeze, when you cough, there are large droplets coming out, and they can make it about 6 feet before they're heavy enough to fall. But I'm sure some of you have been reading online and in other places that there is growing evidence in the scientific community that it may also spread as an aerosol, meaning tiny, tiny little droplets that aren't so heavy, that are coming out just when I talk, that come out when we breathe potentially. And I think this is an area of controversy in the scientific community right now. I'm by no means an expert. I'm a genetic counselor. The other doctors can talk later about this if they feel like they should. And I'm not making any specific recommendation other than to think about, you know, what if there was some question in your mind that 6 feet perhaps isn't enough, or would it be better if it were a little bit more? And some of the aerosol specialists, including one in Portland at Portland State University, is saying something in the range of 10 to 20 feet might be a little more conservative. Now, again, when you're out in the world, when you're at the grocery store, that's a pretty tough one to do. But when you're on a walk and, you know, you see somebody coming on the sidewalk, Personally, I'm veering out into the road. I'm giving myself a nice wide berth, and 10 feet might be more doable in that situation. So it's just something to think about. One thing that I related to really well that I read was, if you were at a park and you saw somebody smoking, how far would you need to be from that person to not smell their smoke? That's sort of a good comparison for this idea about how an aerosol might work when stuff's coming out our mouths, when we seem healthy, when we don't have symptoms, but maybe we're in a pre-symptomatic state and have the virus or that sort of thing. So just something to think about for those of you who are more concerned, which I think is a lot of you. That also segues into the next topic, which is this newer recommendation at a national level by the CDC that we all now wear masks, which can even just be a cloth covering. You've seen the, how to make one out of a t-shirt, bandanas, all those things when we are out in public, which doesn't mean you shouldn't still be doing the physical distancing, but just that it's in addition to the physical distancing. And because my kids are teenagers, I wasn't aware of this till I looked it up yesterday, but kids 2 and under aren't supposed to wear these types of masks or face coverings. They're not recommended for that age group, or for anyone who has trouble breathing, or for anyone who can't remove it on their own. And when I thought about NBIA, all of a sudden I thought, oh my gosh, there are a lot of people who don't have the motor skills to remove one on their own if they're having trouble breathing, or have dystonia, or have other issues where removing it would be a problem. Also, from a developmental or an intellectual delay standpoint, there are plenty of kids we know who are older than 2, but who developmentally might be similar to 2 or younger. So I think when you're considering what kind of mask to put on your child and when, you do need to think about that. Maybe, if you have any concerns, talk to your local team about it. And also, if you do choose to put a mask on them, make sure you're checking on them a little more often, that they can give you a thumbs up or whatever their sign is, but to make sure that things are going okay with it if they can't physically tell you and they can't physically remove it. So that was a new one on my radar. Almost getting to the end of my hopefully helpful additional thoughts about NBIA here. I think the other big one that a lot of you have been asking about, because you have caregivers who come into the home, you have maybe therapists who are still coming in, home health nurses, all these kinds of people who you rely on a daily basis. And now suddenly you're stuck thinking, oh my gosh, I need this person, but I'm worried about this person coming in my home. Some of you are single parents who work. I know some of you are both working in the home full-time right now, which I can imagine. Now you have 2 full-time jobs, right? You're taking care of your kids and you're trying to work full-time from home. So what do? Do you let people into your home to give you support? Again, I know I sound kind of like a broken record, but going back to what I said initially, how you assess your child's current health status. Are they fragile? Are they robust? Are they somewhere in the middle? That's going to help you decide who you let in and sort of how much risk tolerance you have about all this. Some of you who really need help, it might make total sense to have one babysitter, not 5 rotating, but one person you trust who comes in, and maybe that person's circle is otherwise very small and this is somebody you know and you feel confident with. It's reasonable to still be thinking about that if you're not able to get your work done and you're having a lot of trouble at home. Same with nurses, people coming in to do procedures on your kids. The other thing to consider then is, well, how close should the rest of your family members be to that person? Should they be in another room when they're there? There are still ways that you can sort of try to limit and control who's exposed to what. And now hopefully we all have beautiful homemade and home sewn face masks, and that possibly will help as well. And then finally, the other issue that I've seen is some of our older adult loved ones with NBIA, they're living in group homes. Maybe they've been there for a long time. They're happy there. But at this particular time, I know of some who their parents haven't been allowed in a month. They can come to the window and wave, they can talk on the phone, but these places, for obvious reasons, are pretty much locked down. And for those of you who have a loved one in a group home, I know that can be scary. It's probably a little scary for them, not part of their routine. The rest of us are sitting home very eager to write letters and send mail and send encouragement. So if you find yourself in that situation and it's upsetting, don't hesitate to go on the Facebook group and say, hey, can you send mail to my son or daughter, my nephew? The rest of us are really happy to do it. And there are kids cranking out lovely artwork by the pounds in various homes. All these things can be sent. We want to share in a safe way and support everybody. So please, if you're in that situation, let us all know, and we will, I'm sure you'll get a boatload of mail right away. Two other things I wanted to mention. One is I hopped on the website for NORD yesterday. That's raredisorders.org. They had some really good recorded webinars that you can go in and watch whenever you want at your convenience, as well as a couple of new ones that are coming up live starting next week, I think. The other little plug I wanted to make is for something that I started doing last week. Both Stanford and Harvard now have their own online daily health surveys. It's a research study. It's a online protocol. You give a brief consent. So I did this, and then daily I get an email from Stanford that sends me a link, and there are literally 2 questions. It takes 20 seconds. The questions are, how are you feeling today? Do you have any new symptoms? But it's a way that these academic centers are trying to learn how to track and predict and model how things might spread among the rest of us. So I think if you have 20 seconds a day, I can send you the link if you'd like, contact me later, or I think it's pretty easy to find by Google. So I think that's it for me. I'm going to hand it off to the next speakers and put myself on mute here.
Thank you, Allison. Those were really helpful. Our next topic is specific medical problems that increase risk for serious complications from COVID-19, and Susan and Penny will be addressing this.
Thank you. That was terrific, Allison. As you were talking about the Stanford and Harvard studies, I was thinking about it as a COVID-ready, sort of a natural history in the population of a disease that we don't know enough about. And one of the ways we do that is by asking people to participate in online data gathering. So COVID-ready is underway. So one of the questions, kind of the broad topic we were going to start with, Penny and I, was specific medical problems that increase risk for complications, serious complications from COVID-19. So as you know, Penny and I are both physicians. We're different kinds of physicians. I'm a medical geneticist, initially trained as a pediatrician and then a medical geneticist. Penny's a neurologist, initially trained as a general adult neurologist and then as a movement disorder specialist. And then both of us coalescing in our knowledge and expertise in the NBIA disorders. But we come at it from different angles. And so I think we have complementary expertise to help answer these questions. So I might take an initial run at it. And then Penny, if you have additional comments, things you want to correct or add to what I've said, that'd be really helpful. So most of you have read about what this disease looks like when an individual is infected with this virus. It can be anything from no big deal, probably asymptomatic, that is, you never knew you even were infected, through quite mild symptoms, sort of an upper respiratory, maybe a little bit of a cough, to quite a severe flu kind of a disorder with fever, pneumonia, extreme fatigue, and all the way to the full-on disease that is landing people in the hospital, landing people in the intensive care unit, landing people on ventilators with a severe respiratory problem that is very, very difficult to manage. And for some people, this is not something they can survive. So there are 2 factors that seem to go into what puts you at most risk for serious complications from this. One is your the power of your immune system. And as we get older, normally our immune systems are less robust. So my immune system is less robust than Allison's. Allison's is less robust than than her children's, and so on as people get younger. That's for people who don't have an NBIA disorder. Among the NBIA disorders, we are not aware that there are any immune problems in any of the NBIA disorders. There's been some kind of questions in PLAN whether there are, but there's absolutely no evidence, no compelling evidence that there's an immune sort of weakness in any of the NBIA disorders. So it's not so our age is the same whether we have an NBIA disorder or not, I think, in terms of the robustness of our immune system. But there are other aspects of having one of the NBIA disorders that can put us at additional risk for more serious complications, I think. We're all at the same risk, whether we have an NBIA disorder or not, for actually becoming infected, that is, getting exposed to the virus. But for those who have, so the main features, as I mentioned, were fever, pneumonia, or a difficulty with breathing. Some people have vomiting and diarrhea, fatigue. Those are the main symptoms that we're seeing. There's an emerging literature that tells us that there are neurologic features. That is, this virus can infect the brain and can cause a swelling of the brain and complications from that as well. But again, that's not something that's being seen at the mild end of the disorder of the infection. That's something that's being seen with much more severe infection as far as we know today, right? This is a relatively new virus. We're learning a lot about it. In fact, what we know this week is different than what we knew last week. The information Allison was talking about with respect to the airborne virus. So it's not just in droplets that fall quickly, but airborne means it's floating, and not just floating further out, but actually staying floating in the air for much longer. And so, that air into which a virus was expelled is infectious for longer and further. That's something we didn't know a few weeks ago, but there's much more evidence in support of that being the case now. If the person in your family with one of the NBIA disorders has features that are worsened with fever, so particularly seizures, fever would be a problem, and you'd want to be aggressive, as you would with any febrile illness. You'd want to be aggressive with seizure management. The lung disease that is associated with this infection is the biggest risk for people who either already have lung disease, asthma on top of your NBIA disorder, or if the person has difficulty with sort of coordinated muscle movement, which can be a common problem in many people with dystonia, a weak sort of less than fully effective cough. And then for people who have muscle weakness, so particularly in fawn, there can be a weakness in some of the musculature and a difficulty in sort of organizing and affecting a robust cough. So those would be aspects that I would think would put somebody at a little bit of a higher risk for complications from pneumonia. But frankly, the pneumonia itself, which infects the lung tissue and makes it very difficult for the ventilators to effectively put oxygen into the circulation, is really the problem. And most of the NBI disorders, all of the NBI disorders, have normal lung function, the intrinsic function of the lungs. For the vomiting, diarrhea, the intestinal features of COVID-19, which may be a little bit more common in kids. So kids get COVID-19 also. They seem to tolerate it better, and it knocks them off their perch a little less effectively than it does us older people. But it seems like vomiting and diarrhea can be a little more common with fever in the kids. And if the person in your family with an NBI disorder is already nutritionally depleted, if you will, they're underweight, they are not eating well normally, and now they are no longer able to eat comfortably, that can put their general health at risk. Fatigue, for somebody who particularly has weakness in their musculature, fatigue can be on top of their already weak bodies, can make it even more difficult for them to move air effectively and to take care of themselves, just their hour-by-hour needs. I did want to make just one other comment that Penny might amplify, that I do think that older people with BPAN, people who are in the later stages of BPAN, maybe have more complications from the Parkinsonism that comes on, may have other problems associated with a COVID-19 infection, just from their general difficulty with their movements, a slowing of their movements, maybe a slowing of their ability to assist themselves with a cough and other things. I would think those would be complications as well. And with that, I will turn it over to Penny if she has further comments.
Yeah, I don't have a whole lot extra to add. I should just get the thumbs up from people that you can hear me. Okay, good. You know, just to second what both Allison and Susan have said, I think that it's the individual is what determines when somebody is more vulnerable to the complications of COVID-19. So if you have a little girl with BPAN who's running around and doing fine and really hasn't had much in the way of medical problems, they might have some seizures, but they've never had pneumonia, they don't have asthma, they don't have a whole lot of other medical problems. There's no reason to think that they're at much higher risk than another child their age, probably. But if you have someone in your family who has more advanced disease, whatever type of NBIA it is, who might have had a pneumonia, might have been in and out of the hospital a few times with various complications of their BPAN or PCAN or PLAN or whatever NBIA disorder it is, then those folks are probably more vulnerable. And, you know, these extra precautions are things that you may want to pay even more attention to. Seconding what Allison has said, I do think the fundamental principles still apply, that you can keep your loved ones safe by adopting the exact principles that we've all been hammered over the head with. You know, physical distancing, maybe taking physical distancing to as extreme a level as you're able to, the more fragile your loved one is. You know, paying more attention to that, paying more attention to sanitizing surfaces, thinking carefully about the issue of, you know, when it is necessary to seek medical care, when it's a routine medical visit that could be delayed until after this pandemic is over. Those kinds of things, I think, all apply. And I think Susan has actually covered much of the discussion about underlying medical conditions. So it's the things, again, that we've all been reading: lung disease, pre-existing lung disease, whether that's asthma or a history of pneumonias or some other type of lung disease, having diabetes, you know, being a medically fragile child or adult, beyond just NBIA, being at the stage of disease with your NBIA that makes you more vulnerable to complications of any disease, but certainly of COVID-19, I think, are the things to be alert to. And then maybe I can go on, Patty, to the special considerations for NBIA individuals in clinical trials.
Yeah, I had a question first. If someone has had the pneumonia vaccine, would that be beneficial against this virus where pneumonia comes in? Would that help protect them?
So comment about that. So by the pneumonia vaccine, do you mean the Pneumovax and then the flu vaccines?
Yes.
So I do think it's important that people be vaccinated, have their vaccinations on schedule. I know there are mixed feelings about that out there, but I am a big supporter of vaccines. And I think one of the challenges, just as an aside, one of the challenges in this epidemic is flu is also circulating. And so people who have respiratory symptoms, maybe because they didn't get their flu vaccine, are needing to go in and get medical care in settings where we really wish they didn't have to come in. And so, you know, again, I think flu vaccines are a good idea. If you haven't had a flu vaccination, there are ways to now obtain a flu vaccination safely, I think, without really putting yourself at huge risk. But no, the flu vaccine and the Pneumovax will not protect you against COVID-19. Many of you may have read there is a big push to try to develop a vaccine for COVID-19, but that is probably 9 to 12 months off. And so for this season of COVID-19, we are not likely to have a vaccination that is going to protect you.
And is that the same, the pneumonia one? I know my daughter she gets it every 5 years.
I think that's Pneumovax.
That's the Pneumovax?
Yeah.
So that wouldn't have anything to do if she got pneumonia with COVID-19, that wouldn't be helpful?
It wouldn't protect her specifically against COVID-19, but just imagine if an individual were to get the flu or were to get bacterial pneumonia, which is what the Pneumovax protects against a particular type of bacterial pneumonia. If she weren't protected for those conditions, and then she were to get COVID-19, because there's a lot of it around right now, she definitely would do worse. So that's why I'm saying I think vaccinations are important even right now to make sure that you're up to date with your vaccinations, because I think you will be more vulnerable to COVID if you were to get one of those conditions that the vaccines do protect against. Does that make sense?
Yes, one of our participants has said that they were told vaccines could cause regression in BPAM patients. What do you think of that?
So a little bit off topic. You know, it may be something that we should address separately, but okay. You know, there's a lot of controversy about vaccinations across the country. People feel very differently about it. We have not seen any evidence from the natural history study, from kind of what we've seen clinically, no compelling evidence that vaccinations cause regression. But I think that that's a little bit out of topic for this particular webinar. So we'd be happy to, if the individual's got specific questions about that, I suggest they contact us through NBIA Cure.
Okay, I think we're ready to move on then, Penny.
Okay, so special considerations for NBIA individuals in clinical trials. So I think, and maybe comments will correct me, but I think the main clinical trial that is up and running right now for within the NBIA world is the COASY trial. I don't think there is another trial currently underway, maybe in a few people with PLAN perhaps. So let me, you know, I realize that some of what I'm going to say is not going to be that relevant to people who aren't in clinical trials, but let me just address it anyway. So making some general comments, most clinical trials have had to modify their operations in order to continue on track. So most clinical trials require that you go into a research center, that you have assessments on a regular schedule. Sometimes it involves blood draws or clinical assessments, sometimes scans. There's a number of things that can happen in a clinical trial. Almost every clinical trial in the country has had to modify those operations in the face of COVID-19. And there is general support from the agencies that fund those clinical trials, from the CDC, from various federal agencies at a local level. There's a lot of support for changing the way that clinical trials are done during the pandemic. So to that end, if you have not been contacted by your clinical trial investigator with a change in operations, you know, about coming into a medical center, then you may want to contact your investigator about that. For the COASY clinical trial, our clinical trial was always designed to be run in the participants' local community. And so we really have not had to modify our operations in the clinical trial to any great extent. We have had questions, which we've tried to address in a general way on our website, but we have had questions about the blood draws that do need to be done. And because this is a safety and tolerability trial, we are requiring people to continue to get their blood draws with the understanding that if there are very specific concerns for a given individual, we'll kind of discuss that individual one-on-one with the family and make adjustments as we need to. This is a plan that we put through our institutional review board, and also most importantly talk to our data safety and monitoring committee about in our trial. The same kind of thing is being done for other clinical trials around the country. A data safety and monitoring board, which is an independent board that oversees the conduct of a clinical trial, they are weighing in, you know, offering their expert advice about how operations might be modified to keep people as safe as we can. So for us in the COASY trial, it's this balance between needing to make sure people stay safe in the clinical trial while they're on COASY, meaning we've got to assess the safety of COASY, and keeping people safe in the face of a pandemic. So we have made some very specific kind of recommendations about how the blood draws will happen. And we are talking one-on-one with families who have particularly fragile children and adults with PCAN, or kids who are in unique situations like in groups, home settings where they can't easily leave, those kinds of things, to make sure that blood draws can be done appropriately or modified as needed. What else can I say about that? I think those are the main things, is talk to your investigator. Expect not to have to go into a medical center unless it is truly critical for you to remain on the clinical trial and need to go into the study center. And really the only trials where this is happening are you know, certain cancer clinical trials where there's a very specific setting where people have to go in order to kind of get the appropriate safety assessments. So those are the main things I wanted to say about clinical trial operations. You know, for us, we were very fortunate because we'd planned it as a remote clinical trial. We're already, you know, shipping study product to people instead of people coming into the center. We have no requirement that people come into our clinical trial center. And so it's been, we've basically continued almost without a beat in our trial, but many trials are needing to modify their operations.
Maybe I can jump in and onto the next topic, which is making a plan if your loved one falls ill. And then I would invite Allison and Penny also to weigh in here. So ideally, you've made a plan before your loved one falls ill. I think all families with a chronically ill family member, whether it's an NBIA disorder or otherwise, should have a written plan, a written and well communicated plan that is accessible. You don't have to go hunting for it. It's maybe even tacked to the refrigerator. It's already been shared with your family member's healthcare team, and it's updated. It's reviewed probably monthly to be sure it's current, particularly with medications, and it's updated and shared probably at least once a year. There are resources not NBIA specific, but probably don't need to be NBIA specific. There are resources from the particularly the pediatric and emergency medicine communities, and the Patty and through the website will provide a link to a form called an emergency information form that you can fill out. It would provide all of the critical information that a physician would need or a first responder would need in an emergent situation in order to provide informed care for yourself if you yourself have an NBIA disorder, or for a family member. It's really important that you do that way before you need it. So that's a very good thing to be doing. If you do find that your family member, particularly your child, falls ill, some of the hospitals are restricting the number of people who can visit, but more importantly, the number of people who can stay with that individual. So for the kids, that's put a strain, particularly if the hospital is at a distance from the family. It puts a strain on a family where one parent is at home carrying that burden and the other parent is in the hospital carrying that burden. And I do think that it's worth at least requesting an exemption for your family if you think that there's a justification for that, and a need for that, it's at least worth asking for that. Many of the hospitals are doing that to limit your exposure, because hospitals are where sick people are. And so there's a lot more people with infectious diseases including COVID-19 in the hospital. And so it's an effort to keep you safe, it's your family safe, and the person most vulnerable in your family safe. For adults, they also are putting restrictions on who can come, when they can come, and how many people can come. And so those are different hospital by hospital, and you'll want to navigate that with your individual hospital. I think when you have a child, an adult child particularly, who's no longer able to speak or advocate for themselves, or if you yourself are need assistance in advocating for yourself, I think you absolutely are have a right and should have an expectation of being able to be with your family member, or to have somebody along. If you have difficulty yourself communicating, have somebody, your advocate, come along with you to the hospital and serve in that role. I'm not aware, so we work in a children's hospital here, I'm not aware of any situation where a child has been separated from parents and hasn't been able to be with at least one parent during a hospitalization. So it's something you should try and navigate with your local healthcare service. Other comments on making a plan?
I have one question that maybe you can address, Susan. Some people, I think, have had questions, and I've seen talk about how do you know when to go to the hospital, sort of who can they call first? Is there a hotline? Is it their pediatrician? So they don't go to the ER unnecessarily?
Yeah, it's a great question. You don't, with whatever is ailing you, be it COVID related or not, you don't want to put yourself into greater harm by seeking healthcare. It's very much the answer is very much a function of what's driving the questions, of course, but I would have my first outreach be to the people who know myself, if it's me with a healthcare problem and an NBIA disorder, or my child's healthcare team, if it's them. I would start with the local people who know you. If it's truly an emergency situation, you've got your emergency information form, the first responders come, you hand it to them, and they should have a kind of a quick snapshot of your loved one and know what they need to know. Many of the hospitals, and actually many of the outpatient services that are continuing to see people, our family medicine, our pediatrics, our internal medicine, have created very explicit mechanisms, because this is a concern for everybody, very explicit mechanisms for keeping people apart who have possible COVID-related concerns and probably not COVID-related concerns. So you injure yourself in some way, and you need to go to the hospital for an assessment and surgery, they would take you into a route that is entirely separate from the route they're using for people who are thought to be likely or presumed to be infected. So there's been a lot of thought around that within the healthcare community.
I'd just make one other comment that one of the great things that has come out of this epidemic is most medical centers had just a little bit of virtual medicine capability, that they were able to run telehealth visits or formal video visits like this. And one of the things that has happened in the face of this pandemic is those capabilities have been ramped up. Huge resources have been put towards ensuring that telehealth capabilities are really pretty widely available from most major medical centers anyway. And hospitals are really using that to deliver healthcare. And so if it is not something that needs to be, stitched up, needs to really have hands-on, and I chose stitched up because that's probably the most common thing that would send one of our folks into an emergency room that wasn't respiratory related right now. if it isn't something that absolutely has to have hands-on, there's an awful lot of medicine that can be done at a distance, just as we are coming to you at a distance.
Patty, I have one more comment. I can see 2 questions coming in on the Q&A.
Right, I was going to ask.
Okay, so yes, the 2 of you who asked, thank you. There is a form for making an emergency plan that has questions, and you can fill it out. And Susan gave that link to Patty yesterday. And Patty, you can tell them where it's going to be.
On our website. And then also there's a question on what does intubating look like for a person with cognitive impairments? So if they did have COVID-19 and they had to be intubated, this person says that they watched their mother-in-law during intubation for a 28-day period for another health issue, and she had to be physically restrained so that she wouldn't pull her tubes out.
So I can answer that one. Having a breathing tube put in is scary, whether you're intellectually disabled or not. And so before that happens, a person is given a medicine to relax them, to help sedate them. And the intubation, the actual putting in of the tube is done as the person is falling asleep. So they should be relaxed and not aware of the process when it's happening. Once the tube is in, it's it can be very anxiety provoking and very challenging to stay relaxed while you have a breathing tube in. And so those sedatives and those relaxants are continued while a person is intubated. We know that people kind of as they're coming into and out of sedation can become combative, not because they're thinking to be combative, but just it's a kind of a natural response. And so we often will put very gentle, loose restraints on the wrists so that you don't kind of accidentally come up and pull your tube out. It's common to do those things, and it can be really hard to see. My own mother was intubated and had these mild, gentle restraints on, and she talked to me about what it was like to have the tube in. It's really scary. And so the physician putting the tube in would try and communicate with your intellectually disabled family member, or we would have you there to help describe things. It depends on the urgency of the intubation. Sometimes it's kind of a crash situation and there's no time to explain, you just got to act. But physicians are very well aware of the fact that it's a stressful thing. It's actually a little bit more stressful for the people around them than I think the person who's having it done, because they are sedated. If we could sedate everybody, it might be better, but it's not how it's done.
And just one other comment, it's distressing to see somebody be restrained, but it is more distressing for somebody to pull a tube out and then to be in very big respiratory trouble and need to be re-intubated in an emergent way. And so that's what we're trying to avoid. It's kind of, the greater good, if you like. We're trying to avoid what we call a crash intubation, because that is not what you want to have happen. You really, once that tube is in place and the person needs it for breathing, and trust me, right now we are not intubating anybody that doesn't need a ventilator, because we don't have so many ventilators, right? But you don't want to be intubated in an emergency situation after somebody pulls the tube out. So,
yeah. So the restraints they're soft, they're flexible. You can usually get your arms up so far, but you can't get them all the way to the tube. Sometimes for little kids, there'll be just a tube that keeps them straight at the arms so that they can't get their hands to the tube that's bothering them. But the combination of gentle, soft restraints and good sedation actually is an effective way to minimize risk with intubation.
Okay, thank you, Allison, Penny, and Susan. We're going to go ahead and move on now to our Katie Flores, our speech and language pathologist, and she's going to address our topics on coping with extended absence from necessary therapies and telehealth therapy sessions for home exercise program. So Katie?
Yes, thank you. All right, so I'm Katie Flores. I'm a pediatric speech pathologist. I work in a private practice with kiddos ranging in age from just over a year all the way to 17 years old. I did prepare a slideshow, so just bear with me for 1 second. Okay, so since March 16th, my clinic has been using teletherapy. So we have just shy of a month of experience. And I have to say, it's been quite an experience, but luckily I've been really pleasantly surprised with the results. So, okay, so first let's talk a little bit about the research. So teletherapy is nothing new. It's been used mostly to reach patients in rural areas. So probably for the better part of 10 years, probably over a decade now, they've been using it. So that provides us some time to research it. And what the research shows is that telehealth is a very promising method for treating children with speech and language difficulties. There's also a high level of satisfaction for both the parent and participant for speech therapy. And not only on the speech side, but just talking with my occupational therapists and physical therapists that are on my team, we've all of our parents have reported really good therapy sessions. They felt that it's been very helpful. So I can definitely say that we concur with these study results as well. So on the front end, I'd like to talk about if you want to start teletherapy, and then we'll talk about if that is not an option right now. So to start teletherapy, you need, of course, a reliable internet connection, which can be hard to come by right now that everyone needs their internet connection, but reliable enough. A computer, tablet, or phone. The nice thing about living in 2020 is that we have all these different options now to use the internet to connect with people. We always recommend a room with minimal distractions. Even the most attentive kid can get a little distracted by a lot of fun toys or fidgets in their hand. So that's one thing. We like to start out with some success and keep some minimal distractions around. I would recommend finding a place of optimal seating, because a lot of times for kiddos who do have some cognitive impairments, the parent's going to be an integral part of the session. And so the therapist wants to be able to see both the child and the therapist, because you're going to be our hands and helping us throughout the session. And so having said that, we want to make sure that as caregivers, y'all know y'all are going to be our boots on the ground. Okay. So the first section, we really like to help set parents' expectations. It's very much a new platform for us, or for most therapists, as well as it is for you guys. So we really like to know, what is their baseline at home? You know, how much prompting do they need for following directions, for communicating their wants and needs with you? What does feeding look like at home? What is their mobility? Sometimes I feel like we at the clinic can see maybe their best versions of themselves, or they know they're in therapy, so they might act differently in the clinic than they would at home. So, you know, give us the full rundown so that way we are able to be the best we can be and kind of start working on the problems you might see at home, or issues you want to work on to improve. So having said that, we love to know what routines and activities they love to engage in at home. When do you see them engaging the most? I have a lot of kiddos that love sensory playtime. So we will fill a tub with water and soap, and we'll get some of that sensory feedback, and we'll get a lot of good words in, or we'll get a lot of good communication. And if all else fails, snack time can sometimes be your best friend. Food is a huge motivator for most people. So we want to know what their biggest motivators are: toys, food, games, and definitely people. I have a lot of siblings that like to attend my little's speech therapy because if mom and dad can't get them to try something, or if they can't get in their mouth to do exercises, honestly, sometimes the older sibling might have a lot of luck with it. So be open-minded to all of your resources you have at home. And for your first session, kind of going back to our internet, be willing to work with the therapist. Make sure that the microphone and the camera and all of that are working. Kind of troubleshoot it for the first couple of minutes. You might need to toggle with a few things here and there. So just be patient and mindful, and we'll get it all worked out. And then definitely discuss with your therapist when you want to ask them questions. Sometimes a therapist likes to get through most of the session and then leave the last 5 minutes for questions, or sometimes they are ready to answer those questions as the therapy is happening, as you're thinking of them. So just run it by them. It's definitely a therapist preference, but it also just helps to set the pace of the therapy session. Okay. So this was a big question I saw. Is my child a fit for teletherapy? So as we've all said, these are definitely unprecedented times. So I feel like it calls to be a little creative with our approaches. This is one of our therapists doing a sensory feeding session with our owner's kiddos, actually. So teletherapy can help bridge that gap until in-person therapy can safely resume. So I know we've had some really hard-fought wins in therapy, trying new textures, being able to manipulate the bolus, or being able to communicate, whether it's by device or by AAC device or verbally. Like, all of these gains we've made, I know, are hard fought, not only by our kiddos, but, by all the family members who are there every day trying to reinforce these goals. So I would say even the kiddos that I've had that have difficulty paying attention, I feel like the parent and I have gotten a lot out of this session, and the kids have they too have, I really think they've enjoyed the routine of these weekly sessions continuing. A couple of kiddos I had, I will not lie, they definitely did not participate very much the first session, and maybe even the first 2 sessions, but now 4 weeks in, we've gotten some good practice in, and I've been able to give parents some homework. We've talked about goals we'd like to achieve while we're home, or if not achieve, at least things we'd like to maintain, or skills we'd like to maintain while we're at home, and how they can go about doing that. So one of my parents, we probably spent a good 10 minutes talking about what the past week looked like what were the pros and cons, like what went well, what didn't work, how can we make some adjustments this week to change up the routine. So definitely with a teletherapy session, you get the therapist's attention. They're able to observe and participate, or you're able to observe and participate in the full session while we're there coaching you. We're also there to answer any ongoing questions you might have about continued care. And it's our job to be very structured and creative. So we try and provide some activities that you can continue on throughout the week. So the only thing I say is, if you're still questioning, just be sure that, the therapy that's going on, you will definitely be an integral part. But I do feel like all of my parents have felt the benefit of their teletherapy so far. So if teletherapy is not an option right now, I know this is a health crisis, but it's also a financial crisis. So if therapy is not a viable option for you and your family right now, I don't want you to despair. We completely understand and we're here for you. But I want you to be proactive for your child. So things we keep telling parents to keep in mind, the time frame of a typical therapy session for speech, it's usually 30 minutes. Some of my kiddos do have hour sessions. For physical therapy and occupational therapy, it's typically 60 minutes. So that's not a lot of time if you look at the full scope of a week. However, I know you're wearing multiple hats right now, so that probably seems like a lot of time of structured planning and activity for our weeks right now as we're trying to manage homework and groceries and all of the extra things we're having to tackle right now. So having that in mind, I would say go or work on your kids' therapy goals. So that would require you definitely to know their therapy goals. Your clinician is definitely taken to mind those step-by-step goals. So it might not be some big overlying goal. It might just be some small step. We're working on chewing, or we're working on identifying, following a single direction, following two-step directions. These little goals build up to a bigger idea. So if you don't know those specific short-term goals, I would reach out to your therapist, because the long-term goals can seem kind of overwhelming to achieve, but just know that we're taking step-by-step goals to get to that bigger picture. Also, use the precious time you get where you have your child's attention and engagement. I can't say how many in like a 1 to 2 minute time frame I'll have a kiddo's undivided attention, and that's where I'll get them to request something or identify something, or we'll get several consecutive chews, or we'll get really good oral exercises in. So it's not that session we have, it's made out of, very small amounts of time where we get their attention. So I say, if you find your kid engaging in something funny you're doing, or if y'all are really enjoying a mealtime together, like try and instill some of the therapy advice in those small moments, because those small moments will build up. And if you're not building to a fully new skill, at least you're maintaining those skills you have and providing that attention and feedback to them. That is super helpful. Something we've been telling all of our parents a lot lately is that play can be therapy as well, hence the photo on the end. Had a lot of dads engage in tea parties with me with their daughters recently, working on requesting and bringing our cup to our mouth. I've had just parents being silly for the sake of their kids, just so we can work on their skills. And you are your child's best toy. They are they are so excited to engage with you in that play realm. So I would say, don't be shy. Just jump in, have some fun with your kids. You'd be surprised at the goals you can tackle through a fun game or pretend play. And from a speech perspective, play is such an integral part of language. It's really the basic building block that leads to more words and phrases and requests. And with our physical therapist, she made us say that she's been telling parents, it might be okay if they play on the couch some more, if they're climbing on the pillows or something, like let them have at it, let them use those muscles. She's given a lot of recommendations to get a lot of playtime outside. Walking barefoot in the grass can be great sensory feedback, and it can work on balance. And so I know this is a very stressful time, but embrace the play when and if you can. So I feel like I skipped one, but our daily routines. So kind of piggybacking off of that, talking about our meal times and our bath times. There's so many daily routines we have, even the morning, brushing our teeth and getting ready for the day. All of these instilled routines we have, these are great times to start therapy, to target simple phrases, to work on oral stimulation. A lot of kiddos who have feeding issues, you might not have a Z-Vibe at home, but you have an electric toothbrush. So do some brushes to the cheeks or stimulate those lip movements, work on your tongue movements. Let's see, I'm trying to think here.
Katie, we're running out of time. You got a few more words to wrap up. And also, can we put your slides on our website?
Yes, absolutely. Yes. So The last thing I say is if all else fails and you feel like teletherapy is not a viable option weekly, if you feel like there is regression happening, I would highly recommend a drop-in visit, even if it's just one time a month. Drop in, see your therapist, tell them where you're at. They can give you some great tips, and also keep in touch with them via email. These are hard times, and we're here to help, so they will definitely be there for you.
So when you say drop in visit, you mean by teletherapy, just get on in a teletherapy visit?
Right.
Okay.
Yes.
Great. All right. Thank you so much for all your beneficial help. In closing, I would like to again thank all our panelists for their time and the insights they shared today. We are fortunate to have these experts who are always willing to help our families. I'd also like to thank Jeff Cooper of Syndicast, who helped us make this webinar possible. Jeff has been at our last few family conferences handling our AV needs and is always ready to help our community. Again, we are recording this event and will be sending everyone attending a link to view or share with friends and family. In addition, we will have it available on our website. Remember, you are not alone. Stay safe and stay in touch. Goodbye.